So just want to welcome everybody to our near office hours. This is kind of a master class on prepless veneers. We have Dr. Brian Harris here, who's available for clinical questions. Really, the whole concept of this is to have an open forum, a relaxed discussion. If you have questions, please just raise your hand and then I will ask you to unmute and you can ask your question and we'll answer it to the best of our ability. So without that any more ado, Brian, do you want to give a quick intro?
Yeah, absolutely. And I know we've got a couple minutes, so we'll chat until everybody gets logged in, and then we'll be ready to go. So an intro. I first off, it's an honor to be here. I think there's been some very specific times within the world of cosmetic dentistry where something has happened that has shifted the way things are done. And and I see that back in the early 90s. So just a quick story. So I grew up around dentistry. My dad was a dentist. I came and worked for him every summer, $2 an hour, um, doing sterilizing instruments. Where I look at that now, I'm like, as a 12-year-old teenage boy sterilizing dental instruments, like there's probably so many laws being broken. But that's just how it was done back then. And I saw him go through this transformation of being a good general dentist to going to the first ever cosmetic dentistry course. And and it's like it lit a fire underneath him that never stopped. He went on to form a group called LVI, that then went on to branch off into a group called Pack Live, where he taught for a number of years. And so my teenage years were spent seeing him do cosmetic dentistry. And I think that was probably one of the first big shifts in general dentistry, always some aspect of dentistry that was aesthetic in nature. And then this new process comes along and now it's this first like cosmetic revolution. And then 2016, I lived through another one myself with the rise of social media and doctors starting to post their cases on social media. It's something that I started to do, and went from a general dentist that did one cosmetic case a week, which I thought was a lot back then, to doing two or three cases every day, and that's continued for the last 10 years. And for the last 10 years, I've only done cosmetic dentistry. I don't do any other type of dentistry. And specifically during that time, porcelain veneers. I dabbled some with composite veneers. They always looked great when the patient left, but when they came back 6 months later, a year later, is when I would be disappointed. And so I had kind of had my eye on the printed process because I knew the fit would be great, but I knew just the materials weren't there yet. And I'd been watching and waiting. And then last year, I saw this, what I call this next real revolution where the the quality of materials and the aesthetics of materials finally got to a point where like now we can have a printed product and essentially introduce like a second tier cosmetic option within our practice, not just porcelain. I guess we always had porcelain and composite veneers, but most of us weren't doing composite veneers because it was too hard. And so last year I saw this opportunity to have a second tier product and process where if it was done right, we could price it at half the cost of porcelain. It would take half as much time to do, and so it'd be equally as profitable. And and that's why I've gone all in on this stuff. I feel like this is going to change the industry. It will continue to get better and better as the years go by. So I guess I would say for all those on this call, um, you're in the right place. You're one of the first group of doctors that are recognizing this revolution. And the sooner you get good at it and the sooner you start to really master it, the better it's going to be for you and your practice, and more importantly for your patients. What an awesome thing to be able to transform the lives of more patients because now you've got additional products that you can offer them. So that's my story. I practice in Phoenix, Arizona, um, and absolutely passionate about cosmetic dentistry and education too. So my goal tonight and every month when I host this call is to give as much information as possible to shorten the learning curve of what you guys are doing in your practices with the Neer product. I want to show up to all these calls with zero ego. I want all of us to show up with zero ego and come from a place of authenticity and abundance and just share as much as possible so that you guys can start doing cases and feeling confident. And I will tell you this right now, some of the questions you have, I've been asked the exact same questions by doctors that are, AACD accredited, some of the best bonding experts in the world that I know of, that still were confused about knowing how to best treat these products and how to best bond them in place. And so it's new for everyone. So do not be embarrassed or ashamed. If you have a question, ask, because most likely other people on the call will have it too. So before we jump in, I'm going to talk a little bit about case selection. Then we're going to get into bonding protocol. The reason I want to start with those two, and we'll revisit these in the future, it's the two things that will mess up a case if you don't get it right. It's the two things that, if there's a failure, either cosmetically or functionally, it has to do either with the bonding protocol not being done right or poor case selection. So I figure we might as well just jump into that now and shorten the learning curve for everyone. But I would open it up to a couple questions or comments first from the group. Is
We
there?
actually we have one already,
Yep,
Dr.
let's do it.
Harris. So I'm hopefully pronouncing your name correctly. Elmwa asks, I'm wondering if you can share your experience with color shade stability after cementation and also durability compared to traditional prepped. How do you handle the transition from the veneer to the tooth at the gingival margin slash cervical junction? Thank you.
Love it. Okay. There's like three really good questions there. So I'm just going to go right at it and answer these. The best way to handle the transition between veneer and tooth, I would say the best piece of advice I can give is do not use bright colored cements. When you're doing no prep cases or minimal prep cases, whether that's porcelain, feldspathic, so whether that's like lithium disilicate, feldspathic, or 3D printed veneer, do not use a bright colored cement. Use a translucent cement. If you use something that's bright colored, you're going to see that at the gum line, and it's not going to look good. You want to use a translucent cement that will blend perfectly with the natural tooth structure, and so you won't see that junction. When you're trying it in, it's possible to see it in the try-in phase because it's still veneer and tooth, and it's not like together yet. So you may see it in the try-in phase, but it will blend nicely once it's bonded in. Joyce had a great case that she shared recently where she shows that the try-in and then after the cementation, and you can see, how nicely it blends once things are bonded in. So I would say that's the best way to get it to blend is use a translucent cement. What was the other question, Patrick?
The other question is just color shade. No, it was how do you handle the transition from the veneer to the tooth at the gingival margin slash cervical junction, as well as, how does durability
Color stability.
compare?
Okay. Durability and color stability. I'm seeing no issues with color stability after bonding in place as long as you're using a good veneer cement. And when I say a good veneer cement, like tried and true, that would be Verilink, which we'll talk about tonight. Maybe Ivoclar, it's 3M, like Reliax veneer cement, Light Cure, veneer cement. I would recommend a light cure product over a dual cure product um, for color stability reasons. Most good cements now don't have as many color stability issues, but I would still recommend a light cure cement over it and a good, well-known um, veneer cement. Relax Veneer, Link. I know some doctors are using Panavia. Panavia is a great cement, but just make sure you don't use the bright colored cement. And then as far as durability goes, durability has everything to do with proper bonding protocol. Yes, the material is going to not be as strong as Emax, for example, lithium disilicate, where we're looking at what 400 megapascals of um, fracture toughness, tensile strength. When you get into feldspathic, for example, you're like 85 to 90 megapascals when like the old Empress material. I had Empress veneers on my own teeth for 21 years. I had them switched out last year to Emax, but the Empress lasted 21 years, and I had a couple little chips on back premolars you couldn't really see, but otherwise a super strong material in that 160 megapascals range. And that's about where this material is, that 140 to 160 range. So it's a strong material if it's bonded correctly. But if it's not, and all it takes is to get one little single step wrong and it'll weaken the whole process. So if you bond it correctly to enamel, it's going to be crazy strong. Now, if you're lengthening by 3 millimeters on somebody who's got super worn dentition and you're doing things that you shouldn't be doing, yeah, you may be more likely to have fractures, but otherwise, it should be a great material for this type of process.
We got two more before we jump in, and
So,
then I think we should jump into case selection and bonding protocol. From Dr. Dean. Dr. Dean asks, I have a tooth number 8 implant crown that needs to be replaced. Would this be compatible with the new veneers setup? And then the second question from Dr. H, out of curiosity, what do you do for isolation when delivering? Also, cement wise, how do you feel about G-Cem One?
okay, I would say not familiar with G-Cem One. I haven't used it. Um, I would say uh, as long as it's a light cure veneer cement in translucent shade made by one of the top companies, like it will work. We'll keep it simple and say that. What I would not be doing um, is using a dual cure cement if I'm doing multiple units. Um, but we can talk offline about that particular brand. I can do some research on it. Um, for isolation, I am a believer in that, like the whole reason to use a rubber dam for isolation is to make sure that you don't get fluid, blood, anything around the margins and moisture. Um, the most important part of that though is to make sure you don't get fluid, blood, or moisture. And so if you can control your environment, then you don't need to use a rubber dam. I do not use a rubber dam when I see my cases, but I have a very controlled environment with dry angles in place, cotton rolls. I have the patient wide open. I've got, two fingers, retracting everything, and I'm watching the tissue the entire time, making sure that everything looks great. The difference with this type of process versus a traditional veneer, usually with traditional veneers, they've been in temporaries, the gums are inflamed, there's sulcular fluid, there's a lot more to worry about. With this, if you get good isolation with some dry angles, and you dry things off really good and you're in enamel, I mean, you could sit and work for 30 minutes and be fine. So it's just all about isolation. If you're a new doctor working with a new assistant and you're not comfortable with the office, yeah, if there's all these other variables that are going to affect it, yeah, just isolate with the rubber dam. But if you feel comfortable that you can isolate well, then then do it without, and you'll be fine. Okay, I'm going to jump in. Some of the things that
Sounds
we'll
good.
cover tonight may answer some of these questions, and then we'll spend as much time as we need when I'm done answering questions. Again, I want everyone to feel comfortable. So let's talk case selection first, because I think that is super important. I see the cases come through, and I see, and I'm sorry, I will answer the question about the implant crown in this process and how to work around that here in this section with case selection. But I see some cases come through, and I'm like, man, if they would have just taken 2 minutes and just polished two or three areas with the disc or with the burr, like this would go from like a 6 out of 10 case to a 10 out of 10 case. And so that's really what I want uh, everyone to think about tonight is I look at every single no prep near case with the eyes of, is there something I need to prep to give a better result? And if so, then I talk to the patient about it and I say, we can do this without adjusting anything. However, if you allow me to just polish this one area back, it'll take just a second. We don't need to numb you up. It's just in the enamel. But if you allow me to just polish this one area, it's going to give you a better cosmetic outcome. I've yet to have somebody say no to that. And the key is just knowing what those areas are and how to recognize them. So this example here of this case, this would be an example of what I would say is like a true no prep near case, where I'd feel comfortable scanning this. What I probably would do first is I would use a little bit of a laser to clean up the tissue. It's immediate post ortho. Clean up the tissue a little bit and then scan it. But this is a great no prep case. You don't need to prep anything. Everything's aligned. It's going to be a great case. What you don't want to do is don't go in there with a laser and take away 1.5 mm of tissue all over and then scan it and send it in where the tissue's all beat up, it's bleeding. The lab's going to have a harder time designing it. And, if that's a case where you have to use a lot of laser, let it heal first and then come back and do the case. It's going to be better. If it's just a couple little areas like this, yeah, all day long, I'll just trim that back a little bit and then scan it. Okay. So ideal case, adding width, length, fullness, it's gonna turn out amazing. Okay, so let's take it up a notch. And instead of asking the group and making everybody come off mute, I'm just gonna tell you what I see, and hopefully it resonates. Now, if you disagree or if you question any other part of the case that you feel we may want to adjust, then speak up. When I see a case like this, I see nines wider than 8. I see some old bonding here, but I also see this wide distal aspect 8 that's really rounded here. This would be one, and also 8's longer than, or sorry, 9's longer than 8. This would be one where I would say, you know what? This is a great near case without having to prep anything except, I would flatten out the length of 9 and I would take a disc and I would flatten out the distal aspect of number 9 after you take off the composite here. Okay. So it's just this line angle here. You could take a disc and just polish, even if you just roll it in a little bit, you're going to get a better emergence there and it's not going to look too wide. So when it already kind of looks a little bit wide compared to the other one, and it's more that it's really flared out, to get the right look, just polish it back a little bit, and then you'll make sure those front teeth aren't too wide. Now, you don't have to do that. You could just scan this and send it, and it's still going to look good. But this would be one where I'd say a little bit of polishing right here is going to make a big difference. Now, if you're adding a lot of length throughout, then maybe you don't need to shorten this a little bit. But when I look at this and I see, if I don't like to have my veneer even with the incisal edge, I like to have a little bit of a wrap. And so if I'm going to wrap this, let's say by 1 mm, then as I look at these over here, I'm like, man, that's a lot of length I need to add here. I'd rather shorten this by about 1 mm and then bring the final length down to, probably a little bit longer than where 8 is now. Okay. Otherwise, I think it's a great case. You could scan it and have it be good to go. I'll get questions sometimes about let's say this is her actual bite, how she's biting down. See how this is kind of tight right here? I would still scan it and build it, and the Neer most likely is going to wrap the edge, and this will be a little bit high when you seat the case. We'll then come back and polish down the occlusion. Don't try to go in and reduce this first, because then, what happens is if you just build onto this, you can polish down the occlusion, then they'll be tooth on tooth. If you try to grind this down, now you got to take away, half a millimeter, a millimeter, because you're going to have to wrap underneath there. And that's the most likely area for it to fracture. So just build, if the lab needs to overbuild and then you polish it down after bonding in place, then so be it. Looks like a question came through here. So let me. Okay. Good. So question is, are you opening vertical in the posterior? I would say in most cases, no. To really, if you want to do a true minimal or no prep case, to open the vertical, you need to at least open by about a millimeter posteriorly. And the more you open in the back, the more it's going to open things in front. And so I would say only in cases of extreme wear am I wrapping on to the occlusal to open vertical. And right now, Neer works best with like 10 units in the front. In the future, we'll get to a point where we're wrapping occlusals and using this material to open verticals and change bites. But for right now, I would say keep them where they are from a bite standpoint, unless, and we'll talk about some other cases where you have to open the vertical and how you manage that. Okay, so let's talk about this case here. Narrow arch, right? A little bit smaller size teeth. At first glance, like this is, to me, this is a great minimal no prep case. This would be a great Neer case, okay? One of the things you have to be careful of, depending on how wide you want to widen things, is when things in the posterior are really angled in and they're longer, sometimes it can create too thick of a buccal corridor, and it can look a little bit unnatural. And so imagine, let's say you had Neers designed and you wanted to widen things out, let's say a full millimeter and a half, and go with kind of more of a straight up and down look. That means the veneer is going to have to come here, and then this aspect of the tooth is going to be really thick. So you have options. You still just have it designed, bonded in place, knowing it's going to look a little bit thick. Then after they're bonded in place, then you can come back with a burr and relieve internally some of that enamel, and then it will widen up the smile then. Or before you scan, you can take a burr and just maybe shorten a little bit or relieve a little bit before, and then widen things out. Okay, or just don't widen the buccal corridor as wide. But that's one thing that I would say be careful of, and it's the combination of narrow and longer in the posterior. So you want to look for kind of that reverse smile when the smile kind of comes up in the front. Just be aware that these areas can look thick in through here when you're done, but you can always go and reduce that too. And remember, once the Neer is bonded in place, it's solid. You can still reduce enamel after the fact and be good. I always do that without the patient numb. And so if it's getting close to dentin, I'll know when to stop. Okay, next case. So at first glance, you would look at this and think like, great case for Neer, because there's spacing and there's discoloration of the teeth, so we can go back and do 10 teeth and we'll get a great result. These cases can be a little bit tricky because of the flare. And so it's really kind of the distal aspect of, look at the distal aspect of 7. See how it's flared out, but then it's also wide. So sometimes when you start designing these cases as a no prep case, you have to then build out. And so you take something that's flared and it can even look more flared. And so this would be an example of where a little bit of enamelplasty on the distal aspect of like 7 and 10, and maybe even a little bit on 8, maybe not, or 8 and 9, maybe not so much. But I would say for sure on 7 and 10, and maybe like 6 and 11, just to reduce a little bit of that flare is going to result in a nicer cosmetic outcome in the end. And so, if patient will allow it, I will just tell them. So again, the verbiage I use is always like, hey, we can do this without having to touch the enamel at all. We can just take an impression. I can send these off and have them made. The rule though is that if the teeth already have a certain flare to them, when we're having new ones made, there's a chance that it can continue that. And I don't want you to have any more of a flared out look than you have right now. So if you're open to it, what I would do is I would polish back the enamel in just a couple areas. You don't have to be numb to do it. You're not going to feel it. And it's going to give us a better cosmetic outcome in the end. Is that something you're comfortable with? And just leave it at that. Okay, and we can come back to these two in the Q&A. So a case like this would be one that I would say, sometimes what's gonna happen is you're gonna want to do these cases so badly, and it's the perfect scenario where it's a cool patient, cost is a concern where they don't want to do porcelain. You're going to be excited about, doing your first Neer case or doing a Neer case, because every one you do, if you document it right, it's going to lead to another one when you post it on social media and talk about it in the right way. And so something will come through and they're ready to go. And I would say these cases, like, you should pause on and like really think about it before you just jump in and do it. If the bite's already really tight like this, and now you're going to come and add something, to the facial aspect and potentially wrap the lingual, there's risk in things chipping. And so I think you have a couple options. You either just tell the patient, hey, you know what? I think this is going to be a better option for porcelain, but maybe instead of doing 10, why don't we do the front 4 in porcelain? The reason I say porcelain is with porcelain, you can go in and actually prep the teeth on the lingual, create space, bring things forward more, and kind of, jump that bite and have it be something that's stronger in porcelain. The other option you have, and I've done this before, it's not something we talk about a lot, just because, it's one of those things where it's like, well, is that too aggressive? Should we not just do ortho first and IPR and bring those lower teeth back? A lot of times I try to do what's most practical for my patients. So I've had cases like this where there is significant wear, and then I have them open and I look at the lower anteriors and they kind of come up a little bit in the front, or I look at the lower anteriors and they're all kind of chipped and worn down anyway. And so what I'll do is I'll go in and just reshape the lowers, enamelplasty alone, and take a little bit off the facial incisal aspect and just reshape the lower enamel with burrs and discs. And that alone will create enough room to where then I can go and do something with a Neer in this case. Now, some doctors would say, let's figure out, what the root cause of this is, and let's move teeth to the right position first, and then use Neers after that. And I would say that's the right answer. I mean, that's how we should look at every case, is if it's possible to do ortho and patient will be okay with it, then do it. But you'll get in those scenarios where some patients just don't want that. And so if you are going to work around it, that would be another workaround. Okay, but otherwise I would say this is where I start to talk about additional types of treatment. Okay, tough case. See that reverse smile? Longer teeth in the back, shorter in the front. The rule in kind of no prep dentistry or minimal prep dentistry, it's almost always the distals of the centrals, and it's kind of like that facial prominence of the canines. And so if you are going to do some enamelplasty, those are the areas that are going to be the most beneficial to do it. This case is a little unique where she had ortho first and they widened everything out, but now she wants veneers because she wants to change the color. So they widened everything out, and now we're going to have to enamelplasty some of that back to make sure the veneers don't look too thick in the end. So I'd say if it is one that you wanted to do nears on, then little enamelplasty on the distal centrals, and then possibly a little bit on the facials back here. But it's a case by case basis. So this is a case that one of you had sent in. Fantastic case example here. So peg lateral on 7, missing number 10, 11, that canine's kind of shifted into the number 10 spot. And how would we manage it? So it's not the clearest photo because I just took a screen grab of it, but let's talk through it. So if it were me in this case, what I try to do is I start from the back and move forward, and I look for like, okay, if this is going to go sideways, where's it going to get messed up? And for me, it's really kind of in 8, 9, 10, 11 area, right? Or 8, 9, 11, and I can't tell whether this is a retained primary tooth or not, but let's just say there's a good root there, it's stable. We're gonna build off it. And so the reason I say, I include 8 in that is that if this space over here is wide, and if we're going to be using veneers to close this space, and this one's already narrow, I would say I would do a little enamelplasty on the distal of 8 because then it lets us make this peg lateral a little bit wider. And then I would shorten kind of that mesial aspect of 8, and then I would shorten the incisal of 9 so that everything's not built down and has a cant to it. So I'd shorten those areas, and then I would probably try to flatten out the facial of the canine a little bit, and maybe the distal aspect. And this would all be no numbing and enamel only, not super aggressive, but just reshaping that enamel so that the design then can be more kind of the length of 8 and continue back. And I would be comfortable doing nears here. I would raise the tissue a little bit here, and I think it could be a great case. But this is one that I would for sure be doing some sort of enamelplasty on first to get a better result. Okay, so let's open up to some questions here as it relates specifically to prep versus no prep, and case selection, and what cases are good cases and which cases are ones that we should stay away from.
So I think that there was 2 questions that have came in. Dr. H asked, what burr would you use? Just extra fine diamond, making sure that we covered that. And then is there any reduction guide scanning, where and what to reduce? How do you kind of go about that?
Okay, so I would say the burrs I can send you. I'll drop a picture in here, or Patrick, maybe I'll send it out. I'll send it to you and you can send it to the group. But what I would use here would be, I know, guys, I'm terrible with burr names and instrument names. So I'm just going to tell you what I call it, and then we'll find the equivalent of whatever burrs you use. But I would use the 3M Softflex discs, the very coarse disc that's like dark red. I would use that to polish the distal here and to shorten this. I use that a lot to take a little bit of facial body off of a canine, or let's say I wanted to do a little bit more reduction here. I use a red striped diamond burr, the kind of the tapered prepped diamond burr. And so it would take me a matter of minutes. I don't use reduction guides. I think this is one of those types of things where if you just get it close, or if you just do some, it's going to be better than if you did nothing. And so don't overthink it, or don't think about how exact you need to be. Just take a disc and put it on the distal here, prep it back a little bit, just so that instead of it looking like, it's rounded out or it's flared, that it looks more straight up and down, and it looks like you've created a little bit more space for that lateral. Same thing here. I would probably just polish the mesial of 8, make this to where it's more even and flat, and then I would bring this one up to match it. And then on the body of the canine, usually that's where I would just do a little bit at a time. Just tell the patient, like, hey, if you feel any of this, let me know. But what I tell my patients is when we're done, if I give you a mirror, you may or may not be able to tell what changes we made. In this one that we're going to shorten in the front, you'll be able to tell that difference, but you probably will actually honestly like the look of it better because instead of it being angled down, it's going to be more even. But if I give you a mirror after this, it's not going to stress you out. It's not going to freak out. It's not going to look a whole lot different to you. But we are going to be making changes that we can't take back. Um,
We have another kind of good question that might lend itself into a bit of a discussion here, but what are the ages of these patients? And I feel like I can get inside that person's mind of, is there a use case, for younger patients with Neer?
yeah. So I would say um, age range of these patients, I mean, the age varies. I would tell you this. Most orthodontists do some sort of enamelplasty when they finish cases with discs. So I would say know that, it's common and I wouldn't be afraid to do it. Now, if you're getting a coarse diamond out and you're hogging down the facial of the tooth and you're making like drastic changes, then yeah, then I think you need to stop and think about, is this something that's going to cause an issue with the patient? But little changes to the enamel, I think are totally reasonable to do. So I think it's if I adjust this, is it going to make a drastic change in how things look? And if not, then you should feel comfortable doing it. If you're concerned about liability, to me, it's more a conversation and just asking the patient of like, to help me understand your comfort level. When we do these cases, we try to do these we call no prep or minimal prep. Minimal means that some patients are willing to take away a little bit of enamel if it means that it will look better in the end. No prep is that we don't touch anything at all. Where do you stand? And they'll tell you. And if you want to make it less uncomfortable, say, hey, it's usually 50-50. Some patients are comfortable with us reducing a little bit to get a better result. Others don't want us to reduce anything at all. What's most important to you?
I'm actually going to share my screen for this one, Dr. Harris. A doctor submitted this patient and was asking for some input on whether or not this might be a good candidate and looking for your insights on it. Do you have any insights?
Yeah, I can see it here. Can you guys see my screen here?
I'm sharing the photo, but I don't know if they can see your screen. I'll
Okay,
stop
I
sharing.
stopped share on mine.
Yeah, you can share your screen now.
Okay, got it. Okay, so I'm just gonna do it like this. Okay, can you see that, Patrick?
Yep.
Okay, good. So there's two images here. Let me pull up the other image here too. Okay, perfect. Okay, this is great. Okay, this is where your comfort level with cosmetic dentistry is going to be really important in determining whether or not this is a case that you would do with Neer or not. So the things that I see when I see kind of a deeper bite like this, and I see these wear patterns when he's got like, I mean, those wear patterns are like those teeth are gonna glide exactly within those wear patterns. This is one where I would say if you are going to do Neers on this case, I would not lengthen anymore here. You could raise the tissue and you could just go mostly additive and maybe lengthen a little bit on the edge here. But you're going to run into functional issues on the front here. And so this is one that I would say, could be a Neer candidate if you were willing to first maybe do a little enamelplasty here, maybe a couple traditional veneers on these bottom teeth just get things a little bit more stable here and then come to the top. Um, but I would say this is one where you could get into trouble just because of the deep bite and the wear patterns that are like really locked in, and the fact that it's a male that is going to tend to grind a little bit more heavy here. Okay.
Great.
I would say if there's a doctor on here that has extensive knowledge in cosmetics, you probably already have an idea of how you would handle this. If I was going to, let's say someone put a gun to my head and said, you have to do Neers on this patient. How are you doing it, Brian? That's where I would come in and I would say, okay, let's let's do a couple full coverage down here. I would, if I'm doing the least expensive way possible for the patient, I would enamelplasty the distal of this lateral. I do the same thing here. I would do some enamelplasty on the canine. So I would get the lower arch in a better position aesthetically, and then I would check the bite in the back and make sure it's stable, and then possibly use uh, Neers to make some of the changes cosmetically. But frankly, this is one where I'd be having more of a conversation of, hey, this is a great material, but you're really a better candidate for porcelain. What you don't want to do is go down this path, have it fail, and then be stuck having to undo things.
Great feedback. Thank you so much, Dr.
That helpful?
Harris.
Okay. And that's it.
Next. Oh,
Am I
go ahead.
back on my main screen now, Patrick?
Yeah, you are.
Okay. Yeah, I would say, guys, that's the hardest thing is when you have somebody that's like ready, you have to think about, okay, what does this look like in 6 months from now? Because sometimes cases do fail, and it's like, how am I going to get out of this in 6 months? If it's a super cool patient, they've been with you a long time, it's somebody that you want to do something special for, and they got a wedding coming up, and it's also the type of patient where you're like, you know what, if this doesn't work, I'll hook them up and I'll just do traditional veneers on them anyway, and I'll make them pay the lab fee. It's like, yeah, then do it. You know those patients, but if it's that picky patient, you're seeing them for the first time, you don't have a relationship, they don't know you, then no, this isn't a candidate for veneers.
Wonderful. Next question from Dr. H is, what is the minimal overjet you look for to qualify patients as a good candidate? Is there light occlusion on near restorations when they're cemented? Thank you.
Okay, so I would say, let's go back here. I would say when I'm evaluating a case, it's less about how much overjet, how much overbite. It's less about those types of, or another one that we're taught in school is like golden proportions. So it's less about like the logical, practical side, and it's more about, hey, if I were to add a millimeter of length and I were to widen and brighten things up, could this patient withstand that? And is it going to be something that's going to cause issues? And if I look and there's no wear patterns and things look really good, then it's a case I'm like, yeah, I'm going to do Neers on this case. If I'm looking at this and now the bite's a little bit tighter in the back, then I'm looking at that saying like, okay, I still think I can make this work if we widen things out. But this is also the type of case where I'm not going to leave occlusion super heavy on the Neers themselves. I want to make sure I stay on natural dentition. So it's less about like measurements for me and more about looking at the case and knowing whether or not it's going to get me in trouble or not. And the great thing about this group is that like I've learned some of these things over time from my own failures. And the great thing about this group is you don't have to go and learn it first. You just bring it to these monthly calls or these weekly calls, or drop it in the WhatsApp group and say, hey, yay or nay, am I going to get in trouble with this case or not? On this one, I'd say, do it. I think you're going to be good. This one, I'd say, hey, do it. It's going to look good. Make sure those back teeth don't look too thick. On this one, I'd say, ooh, yeah, you can do it. Make some changes. I would say, heck no, stay away from it. On this one, I would say, maybe not the greatest near case because of how wide the smile is. On this one, I would say do it if you can do some enamelplasty first. So I would say lean on this group for guidance.
Love it. We have another question. Quick question on diastema cases. With a 5 to 10 millimeter diastema, where do you see the cutoff for going straight to no prep veneers versus using orthodontics first? I use clear aligner Candid Pro. Do you prefer closing as much space as possible before additive veneers, or do you feel it's acceptable to restore directly if the patients want a longer tooth display?
Yeah, so when it comes to diastemas, let's go back to this case. So in cases like this, so you just have to look at the size and shape of the teeth. See how the teeth are kind of more rectangular? They're almost more narrow. In cases like this, it's like you can just close the diastema with how it is. We don't need to move things anymore. Let's say though that this diastema was twice the size and everything else was pushed back, then you have the option. You either move things with aligners first, so you don't have to do as much prep, or you can still do that case with the large diastema, but you're going to want to prep on the distals of those centrals to make sure those front teeth don't look too big. I believe it or not, the biggest issue with diastemas is when they're not very big. Like if it's a smaller diastema like this, and you try to close it, it can almost leave like an area on the lingual that's going to pack food. So in some cases, it's better to leave the diastema a little bit bigger because you can take the veneers through the diastema, where in other cases, you maybe move the teeth first. Now the diastema is more narrow, but now you have a harder time closing the gap without it leaving space on the lingual side of the veneers. So I would say it would be on a case-by-case basis. Whenever a patient's willing to go through ortho, just move the teeth and do a better spot first. It's the patients that aren't willing to go through ortho where you have to come up with, where are you going to, like, where's the trade-off? Are you going to prep on the distals and then close it all in approximately, or where's the trade-off?
Another question here. If a patient has an implant and implant crown on central and the goal is to have a single shade matched in good alignment, would you try a Neer with the new implant crown? If so, how should we communicate with the lab to ensure desired outcome? Thank you.
Okay. So we'll go to this one because it was in the chat. So I would say, let's take this case, for example. Patient has gone through Invisalign. I can see the buttons on there. Let's say they were done. And let's say this is as good as we can get with Invisalign, and now they're wanting an ideal smile, and they're wanting something fuller and brighter and more ideal shapes to things. I would say, and for really picky patients that want ideal aesthetics, you're just better off using a porcelain material for that. The reason being is on implant crowns, to get this to look good, we have to. So let's say we were going to restore 10 teeth here. To get number 8 to look good and have these, 7 and 9 also look good, you're going to want to carry the porcelain interproximal here so that we can change the shape and close kind of this black triangle. And so you're going to want to carry the porcelain interproximal on both of those teeth, which usually means to do that, you're going to want to prep a little bit so that you don't have an undercut here. And this starts to get a little bit complicated as far as design goes. And so this is one where you're going to be able to control the case better by prepping. And so this is one where this would be a prepped porcelain veneer case for me in my practice. If you were to do this as a no prep veneer case, what I would do is I would do the veneers first, and then I would come back and design the implant crown after that. You would never want to do the implant crown first and then try to get the veneers, just purely because of trying to close this gap. But I would say do the veneers first, try to get them to look as good as you can, then come back in and do the single implant crown. But probably if it were my patient, I would say in this case, I would go more conservative here, and I would probably do 2 units. Laterals look good. Take the buttons off, do 2 units, but just let them know like we're going to prep this so that we can make 9 wider and make 8 not as wide. And then I would just do it as a two-unit porcelain case. Okay, let's say it wasn't this case, and let's go back here. I'm just trying to give you guys a couple examples here. Okay, so let's say this was the case and number 9 was an implant, and you needed to do an implant crown here, but you also wanted to use Neer both from a cost standpoint and to go more the no prep route. I think the order of operations there would be it would be Neers first, and then I would do the implant crown second, purely because if the implant crown is going to be porcelain, it's easier to customize a porcelain restoration to fit the color of the veneers than it is to do an implant crown and then try to get Neer to match that perfectly. You have more freedom with porcelain to change the color than you do with the Neer. So that's what I would do is I would reshape whatever's in there now, whether it was a temporary or an old porcelain crown. I would get it the right width and everything that I wanted. I would design the Neers around it. I would bond them all in place. Then I would take my final impression for a final implant crown and design it to be a perfect match with everything else.
I don't see any other questions right now. Is there any other questions from doctors in this session?
Okay, I'm going to jump into bonding protocol. You good with that,
Yeah.
Patrick?
Yeah.
Okay. Okay, bonding protocol. So actually, we'll talk about this case. This case I finished a couple weeks ago. I'm going to walk you through what I did from a case design standpoint, and then we'll get into the bonding protocol to follow. So great example of, this a great Neer case. I could have just done it without prepping anything at all. But when I see a diastema here, and then I see this one kind of flared out, and this is already more narrow than this side, I see this as being, something where if I can just get a little bit more space in this area, then we're going to get a better result in the end. So this is what the prep design looks like, just so you guys can kind of see. I did a little bit on the facial of 11, and then the rest is just a disc to flatten this angle out, and then a red striped diamond burr to polish a little bit on this guy here. Now, this would be probably the most aggressive that I would do if I were you when it comes to, not numbing and doing some minimal prep. You can see like this is taking away a decent amount where they're going to notice this difference here. But what it allows me to do is, and this is half the veneers tried in, and this is the other half. It allows me to now slenderize this tooth and get a more ideal proportion to everything just by making that simple change. Now, every case you do, you're going to look back and think, man, if I could do that again, I would do something different. And this is a great example of that. I look at this and I'm like, man, I should have just used the laser and raised the tissue a little bit on number 8 to match 9. Because if I would have done that, we would have had an even better aesthetic result here. And so this is everything tried in. This is with water. A translucent cement's going to mimic essentially what water is going to give you. So felt comfortable with it, bonded the case in place. And then this is the final. So I want you to notice the difference between the final and the case bonded in place. Okay, look specifically at like number 10, for example. Okay, so I flattened it a little bit. I've flattened the embrasure here, and I've shortened it a little bit. Once everything was done, like this is a great example where this would be like ideal golden proportions. The proportions are right, everything looks great, but sometimes guys, like, you'll finish a case, and while the science tells you everything's exactly where it should be, it's just too much for their face. And so if that happens, the great thing about Neer is you can come in and you can just shape. So look at the length difference on 9 here from the before to the after. It's not a ton, but I've come in, I've taken probably about a 0.5 millimeter off, and a 0.5 millimeter here. I've squared things up a little bit, and just those changes alone made it flow more nicely for him, and it didn't look as bulky. You can also see on the canine here where this embrasure is more closed off. It's a little bit more rounded here. We just open that up a little bit more. So if you see the case and it feels too big, too bulky, and the way I explain it to my patients, if it just feels like too much teeth, it's almost always around the laterals, the embrasures around the laterals or the mesial of the canines. So don't be afraid to get in there and shorten things up a little bit to perfect it. Okay, so bonding protocol. This is, if you have to follow, if there was one protocol that I would say everybody should follow, it would be this. This is what Mod Institute teaches. This is using some of the most well-known products that are tried and true. Like, this is the protocol I would follow. Okay. After you've tried things in, you're going to want to lightly sandblast the intaglio surface of the veneer. Okay. Just lightly. Don't go crazy on it, but lightly sandblast it. After that, if step number 2 is optional, you do not have to use like a monobond plus. Technically, this is a highly filled resin. So it's a resin highly filled with porcelain. But it's still a resin-based material. So you don't have to use a monobond, which is like a silane and a primer. But some doctors like to use it because they like feeling like the porcelain particles that are in there are now going to be silanated. Although you're not porcelain etching this, it's just, if you want to do monobond internally, you can air thin it. The most important step, though, is for sure number 3 is using the bonding agent on the veneer. So if you just want to sandblast it and then use the bonding agent on there, want to make sure you have a good bonding agent on there. Air thin it. Don't cure it, but make sure there's bond on there. And then you're going to fill it with your light cure veneer cement and cover until you're ready to seat it. Where doctors get thrown off is we're not used to not porcelain etching. So they're going like, they're doing a porcelain etch, they're doing a silane, and then they're not using a bonding agent, or they're porcelain etching, and then going to a bonding agent, and that's going to mess with the resin of the veneer. And so just follow this protocol, and it's going to be the most predictable protocol for you. As far as the teeth go, yeah, use phosphoric acid. If you're in enamel, you can go 20 to 25 seconds because you're in enamel, you're not in dentin. If you were in dentin, I would do a little bit less there. And then same thing, you're going to use the bonding agent on the tooth, air thin it. I like to cure my bonding agent on the tooth. Some doctors, and educators teach that you don't need to, and you don't need to. If there's any risk of things not fitting, or if the fit's really tight to begin with, then you don't have to bond it. You can just leave it, and then you can bond it all at the very end after the veneers are sat. But I still like to light cure on the tooth. Okay, and that's the protocol. That's the process. I would say usually this is where a lot of questions come up of like, can I use this bonding agent? I have this random cement. Like that's where you start to get into trouble if you're using certain bonding agents and not the proper cements. I would say, invest in, get the starter kit from Ivoclar. It has all this stuff in it, so you don't have to go and buy it all. It'll be enough for you to seat a case or two. But then just invest in this just for your near cases, and it'll be worth it.
We had a quick question, Dr. Harris, which was, would Ivoclean replace sandblasting?
Um, yes, it can. It can. If I was going to do that, I would still, okay. If I was going to use Ivoclean, I would still sandblast and then use Ivoclean and then a bonding agent. If 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 you don't have a micro etcher sandblaster, you can buy them super inexpensively, like on eBay. Um, and just get a little 50 micron sand for it. It's worth having one. But if you, let's say you're in a bind and you had to bond, then if you went with Ivoclean and then a bonding agent and did not sandblast, like that would be okay.
Any other questions around bonding
And I would
from?
say back to what we talked about at the start, don't use super bright cement. It's going to be easier to see at the margin. And if you have a failure, always look, is the cement, is the resin on the tooth or is it on the veneer? And that's how you know if you're having issues with how you're treating the veneer versus how you're treating the tooth. Most of the time in these cases, I'm seeing that it's left on the tooth and not on the veneer. And so if that's the case, just go back to this process, this protocol.
Well, I know we're at the top of the hour, but I want to make sure that if anyone has any other questions, now's the time. Would the difference, would the different thickness cause any color match example in the back teeth? And we have,
Yes. Yes, great question. Okay. So two things are going to happen. I primarily am asking for minimal anatomy on the facials of the anteriors. What happens when the anatomy gets too deep on the facials, then that's where you can get hot spots or like the tooth showing through. And sometimes you don't see it until things are bonded in and then you get a dark spot. So I just have them do minimal anatomy on the facials. Sometimes what happens is you got a really narrow arch and you're widening that buccal corridor a decent amount. And so that material is going to be thicker and then the front teeth are going to be thinner. So sometimes it can create a difference in color. I find that that's more of an issue with brighter ceramics. So if you're going with like a bleach white shade and it's really thick in the back and then thinner on the front, that can be an issue. The way around that is just make sure that just have a little bit more thickness on the facials of the anteriors to try to avoid that.
great. And I think we're going to be going out with our last question here. I submitted a set of Neer veneers and my hygienist removed the glaze on them. What can I do now? Can I reglaze with anything?
Yeah. Okay, so it's a good question. If let's say the hygienist removes it, or this has happened to me, so I'm just telling you. Let's say I get a actually it happened on this case. See if you can see it here. Okay, so I sat everything in, and aesthetically, 12 was just like kicked out too far, and I didn't like it. And so I knew though if I took a burr to it, I was going to remove the glaze, and then I wasn't going to be able to get that same shine back. If it's on one or two teeth and it's in the back, or if it's on the distal aspect of a tooth, it's not going to be noticeable. So make the adjustments that you need and then hand polish it down with your porcelain or your composite polishing kit. And then use a brownie point, an amalgam polisher, a Shofu brownie point with in a high speed with a lot of water, very light pressure. You'll get a really good shine on it. It's not going to be exactly the same as the rest of the teeth, but they're not going to be able to feel the difference to their tongue. The only time you'll see the difference is if you blast air and dry everything out, you'll see that that one tooth is going to have a little bit more of a matte finish versus a glossy finish. Now, let's say the hygienist did it to all of the teeth and or let's say you sat a case in and patient was really unhappy and you had to go and do a lot of facial adjusting. Don't create a problem if one doesn't exist. Meaning, instead of telling the patient, well, if I do this, it's not going to have the same shine. If the case is in there and it's too bulky and they're not happy, just say, hey, not a problem. Let's get in and reshape it. That's one of the benefits of this material is we can reshape it. We'll polish it back up. Go in there, reshape it. But as you reshape it, polish everything. Polish the glaze off of everything, and then go back and high shine hand polish everything so it's all the same shine. I'm telling you right now, most patients are not going to notice a difference in how it feels. When it's wet, you can't tell the difference. Only when it's super, super dry would they be able to tell the difference. And so, I would do that over trying to go and add a glaze after the fact. Like you could use like a Palaseal and you can add the glaze and then just hope it doesn't wear off. But I think there's more issues of staining and things like that down the road. I would say if you have to convert it to a hand polish, convert it to a hand polish. It's still going to look great. Most printed cases that I've done about 30 cases now of 10 units or more. And I would say 25 of those are hand polish only, and 5 of those are a glaze finish like this. And in fact, all 5 of the cases that I've done have been Neer cases when it's more of a glaze finish. So it's going to look great either way. It's just a little bit different look.
Great.
Okay.
I mean, we have a couple other questions, but
Let's just go. I'll go quick.
Okay. First one, do you see that Neer stains more in the material than other materials out there?
I have not seen that. I've not seen it yet. Now, granted, on some of these cases, we're only, 6, 5, 10 months out. But I don't see that it stains more. I will say that where it will stain is if you bond. So when you bond these in place, you're not taking a sickle scaler after and then flicking off cement. It bonds to the veneer. Like you're taking it off with a like a mosquito diamond burr. You're polishing the margins. So I would say go back and really polish those areas really well afterwards, and you'll be fine. If it does happen that things do stain, I would tell patients if they're like, hey, how long is this material going to last? You know what? The great thing is like it's a new material, so it's made from some of the best materials out there. The one downside is we don't know because we don't have studies yet, 3, 5, 7 years out. What I will tell you is if you feel like you're starting to build up a little bit of stain, don't stress. Come in, we'll polish it out, we'll get things, looking good again, and you'll be good to go. If it becomes an ongoing thing, then we can talk about solutions on how to fix it. But that's one of the trade-offs of hybrid material versus porcelain. But the great thing is it's easily fixable by polishing it out. Next one.
Then are they single shade or are the incisal edges stained for translucency?
Single shade. Now, if you want to get, and maybe we can do this on one of the calls, if you want to get creative and add some translucency, I'll show you how you can do it by adding to the internal aspect of the veneer instead of on the external aspect. My worry long-term with the materials is the more we try to mess with the customization with glazing and staining on the outside, I just think there's more risk in that stuff staining or becoming the issue down the road. However, you can go on the internal aspect of the veneer and add a little bit of composite stain there, some blue composite stain right on the incisal edge. You can take a little burr and kind of make a little trough there and add a little bit in there, smooth it out, and get really nice effects without it affecting the bonding of the veneer. Now, those are a little bit more advanced techniques that you don't do that on your mother-in-law, but it's if you need it to save a case, it's doable.
Great. And last question is with composite polish, like what composite polishing do you like? Just brownie points?
Yeah, I mean, I would say the kit that comes with the Avoclar starter kit works great. Um, Use that. It works great. What I find though is I'll almost always go at the very end with a brownie point, high speed, high water, very, very light pressure, and that gets like a really nice shine. I've also seen like the rag wheel at the very end, you know, if it's more of like a you're just polishing, use that. But again, when most of the time when you're seating these cases, you don't want to do a bunch of facial polishing. It's mostly right at the margin. That's also the reason I like the brownie in a high speed, a brand new one with a really pointed tip, because I can put that right along the margin and just polish that out. And it's hard to do that with a cup polisher without hitting the tissue or hitting the rest of the tooth. So I would say just try it once. The secret is that it's in a high speed with high water, and that's what makes it easier to use and easier to kind of control the point tip.
Perfect. Well, I just want to say thank you for everybody that stopped by tonight, and a big thank you to Dr. Harris for sharing your words of wisdom and answering so many questions. There are going to be plenty more of these, so keep an eye out in the WhatsApp group. That link's been dropped in the chat a couple of different times. So come there with your questions, come there with case reviews, come there to, show off your work. We love it all. And the recording of this, we'll piece it together and share it with everyone in that WhatsApp group. Thank you, everybody. Have a wonderful night.
Thanks, guys. Have a good night.